Hi, Keith.
Hi, Tilak. How are you?
I'm good. I'm good. How are you? Our situation is in KL is not very good. We are in a lockdown now from last 2 days.
As you're probably very well aware, the UK is not in a good state
I
either.
know, I know. Yeah, that's right. Nowhere is in good shape actually. Sri Lanka is even worse now.
And we shall see what the next few months bring.
Yeah, did you get your vaccine?
I've had my first dose, yes.
Right.
Tumor, and immediately a picture comes to mind, a very clear picture, and actually a rather good looking picture as far as tumors go. And but as always, there is a but. There's a but with everything, and the but with this is that we sometimes get too fond of our classifications. We get so fond we don't feel like letting them go. Or at other times we sort of let them go a little too fast and then have a problem getting back, like what happened with the OKC. So the balance, it's all about the balance. And so Today we are deciding about CEOT. Where does CEOT stand? And if you have that question, you have to keep watching to hear Professor Keith tell you about that. I'm Dr. Mandana Donahue, and it gives me great pleasure to introduce the very well-known Professor Keith Hunter. I think people from around the world are logged in and waiting to hear him. And sorry, one second. Yes. Yes, he's going to be talking to us about calcifying epithelial odontogenic tumors, looking backward and looking forward. He is very well known, so a very, very short introduction. He's a professor of head and neck pathology and honorary consultant in oral and maxillofacial pathology, University of Sheffield. He's the extraordinary professor, University of Pretoria, South Africa. He's the adjunct professor, Manipal Academy of Higher Education, India, and leads a research group focusing on molecular and cellular biology of head and neck cancer with external funding and wide collaborations. He's the author of 101 original peer-reviewed articles in addition to 12 book chapters. So now with that, I will hand over to him. And Professor Kapaga Selvi is moderating the session today. And also with us, we have Professor Tilak Ratne, who again, we don't really need an introduction to. So I think with that, I'll just now stop and hand it over to you, Dr. Hunter. Please take over.
Thank you, Mandana. I'm just going to share my screen.
Yes, please.
There we go. Well, thank you. It's really my great privilege to speak to so many this morning. Well, for you, it's this afternoon. For me, it is still this morning. I have been discussing these sort of presentations with Mandana for quite some time now, and as many of you are aware who know her well, she's a really very persuasive lady. And I think this is a great opportunity, and the system that she's put together for this ongoing education in oral pathology, oral maxillofacial pathology, head and neck pathology generally is absolutely fabulous. And I think she's to really be congratulated on what she has done in putting these together. Now, I love odontogenic tumors. And whilst I have been looking at a wide range of biology within the head and neck region for a number of years in my research group, and quite a lot of that is primary cell biology and head and neck cancer, as an oral pathologist, I always come back to odontogenic tumors. And I am probably far too enthusiastic when I'm teaching my undergraduates about just how fabulous they look histologically. And I think they think I'm a little unhinged because of that. There's a lot of detail in odontogenic tumors that perhaps we sometimes gloss over, and they are, when it comes down to it, really quite rare tumors in the whole panel of human tumors. And so they are perhaps to a certain extent really quite an esoteric interest, but I think they are fascinating and they do bear out quite a lot of scrutiny. I have had an interest in a while in CEOT, mainly because I have been viewing the classification as it has developed over the number of years since the initial classification, which in 1971. And we've seen the classification of CEOT grow and develop and change. And as Mandana indicates, sometimes these seem to be one-way streets. And then how do we integrate new knowledge into that? And perhaps the new knowledge might shine a light on things that we thought were particularly in the right place in a classification, but new knowledge shows that they shouldn't be. And I think there are certain elements of the biology of CEOT which bear on that. Anyway, with that, without further ado, I am change slides. There we go. I'm lecturing from home today. I'd fully intended to be in the department. Hopefully, as you can see, there has been a large fall of snow, and so I'm from home. So hopefully my internet will survive okay to give this talk. For those of you who don't know where Sheffield is, we are right in the geographical centre of England. I'm Scottish by background, but I've been in Sheffield now for over 10 years. If you want to see the sea, you don't live in Sheffield because we are the furthest point from the sea at any point in England. It is a post-industrial city, very famous for steel production, and there's a lot of ongoing development in Sheffield at the moment. And Sheffield still continues as a steel-producing city, but it's very specialised steels, particularly for the nuclear industry. And it's then developed, as many of the UK cities have, as a service centre city, largely. The University of Sheffield is on the west side of the city centre. It is one of the group of universities in the UK known as the Red Brick Universities, which were formed at the early part of the 20th century. And it was formed by the merger of 3 colleges, which included the College of Medicine. It now has about 25,000 students. And over the years, we have had 5 Nobel Prize winners, including those such as Hans Krebs, who some of you may very painfully remember from having to learn the Krebs tricarboxylic acid cycle in biochemistry. So this is the university campus looking from the west. In the foreground, you can see the large buildings there is the main general teaching hospital. To the left of that is the maternity hospital, and just tucked in between them is the dental hospital, and next to that the cancer hospital, and a little to the right the children's hospital. So the whole medical campus is together, and the rest of the university spreads a little bit into the background in that, down towards the city centre. So it's a large medical campus which is in the city, right in the centre of Sheffield. This is our dental school, and it has associated with it a dental hospital, which is called the Charles Clifford Dental Hospital. And these buildings are linked together. And as an overall institution, we have about 65 permanent academic members of staff. And mixed in with that are those who do teaching and research, some do teaching only. We have our clinical colleagues from the hospital as well, who will contribute to a lot of the teaching. And we have a large student cohort, although perhaps not as large as some of your institutions. We intake about 70 undergraduate dental students per year, but we also have a very active hygiene and therapy school, and our other students who are master's postgraduate taught students and PhD students, as you can see. Now, some of you will have followed the history of this department in Sheffield, the oral pathology department, because it predates me by quite some distance, as you can be aware. On the photograph on the left here was a photograph that was taken at the time of the retirement of Professor Chris Franklin a few years ago. And to some extent, other than the lad on the right-hand side, the 4 there were the mainstay of the oral pathology department since the early 2000s. And these are Professor Paula Farthing, immediately on the left, Professor Jeff Craig, who some of you, or many of you, will be aware of in terms of the paradental cyst of Craig and other things that he has done over the years. Professor Chris Franklin is in the centre, and I'm going to mention him again later. And then Professor Paul Spate, who I'm sure virtually all of you will know and remember. The department has changed. All 4 of these have now retired. And the photograph on the right was taken at about the time of the retirement of Paul and Paula. And the department was then, I took over as head of the department at this point. And there we have some of the current members of the department. Standing immediately on the right side is Dr. Dan Brierley, who's one of our new academic consultants. And in the middle, next to me in the back row, is Dr. Ali Karam, who's our senior clinical lecturer in oral pathology. So the 3 of us form the senior clinical academics in the department. So as far as CEOT is concerned, I thought it's good to start at the beginning. The beginning, of course, if any of you are aware of the Sound of Musical and the songs in it, is a very good place to start. Whilst we think of CEOT as largely being the Pindborg tumour, there are descriptions of this lesion which predate that, and in particular is the one in the American Journal of Pathology by Tumour and Goldman 10 years previously, which describes 2 different forms of odontogenic tumour. The first of these is the calcifying adamantinoblastoma, and that is what we would probably term now the CEOT. And then there is the adenoid adamantoblastoma, which perhaps would understand more to represent the adenomatoid odontogenic tumour. But the first clear description of the main histological features of the CEOT was in Jens Pindborg paper, which was published in 1958, where he published 3 cases of quite a distinctive odontogenic tumour, which had extensive calcification. And the term which he used was invasive. Of course, we used that for malignancy. So it certainly was infiltrative in a way similar to how we understand amyloblastoma to be infiltrative within the confines of the jaws. It had very characteristic cellular features. These were large polyhedral cells with obvious cell boundaries, and in some of them there was intracellular degeneration. There was marked nuclear variation, and deposits of a homogeneous substance, which we now know to be amyloid, but at that point was unidentified. Over the succeeding years, there were a number of papers which were produced. And at that point, I'll bring Chris Franklin back into the story, because he had gone and spent some time in Copenhagen with Jens Pindborg a few years later to have a look at the first large series of CEOTs, which was published. And you can see that was 113 tumors. And this was, in many ways, the main body of work which then gave rise to the entry of CEOT into the WHO classification in 1971. Some of that had done before. This is the paper was actually published in 1976. We can see here 2 main surveys of CEOTs from the literature. The original first large series from Franklin and Pindborg, who looked back at a number of case reports and case series. And then the very useful series of Bruno Čerkanović and Ricardo Gomez, which has been coming out, as many of you will have been aware, on a number of different odontogenic tumors. They published their survey of CEOTs in 2017. And you can see here that, in fact, in the number of years, in fact, the best part of 40 years, which has passed between these 2 series, that there's quite a lot in common. The ages are roughly the same. There's a roughly similar male to female ratio that is dominated by the mandible, although more recently not quite so much. It's a tendency more over the period of time, more peripheral lesions have been identified, which we will talk a little about later. Radiopacity is present, very commonly associated with a tooth, and there's a recurrence rate which at the time of the Pindborg and Franklin series was not estimated. We published in 2019 a series of the Sheffield odontogenic tumours overall. And this was work which was led by Samadara Sirwardena, who was with us as a training fellow from Tilak's department in Sri Lanka. And at that point, we had 28 CEOTs to have a look at. Most of them were referral cases, and they had a very similar age range and male to female ratio, which tied in very nicely with that which was published in the literature. However, when we have a look at that, as I say, the vast majority of these were referral cases, and it's very difficult to draw anything meaningful from the difference on them. It's a very interesting way to look at the pattern of disease when you're looking at what comes from your local area and what then comes as tertiary referrals. But there wasn't anything very much different between the 2 groups for CEOT. Overall, the groups as here, as you can see, they are mostly occurring in patients who are younger to very early middle age. Most of our cases were in the mandible, which is in keeping with what's in the literature. And there was quite a wide spread of lesions throughout the jaws, both mandible and maxilla, overlapping sites, some including involvement of the maxillary sinus, as you can see. So this brings us to classifications, of course. Now we're dealing with the 2017 classification of odontogenic tumours, where the headline in that text are that CEOT forms about 1% of odontogenic tumours. Male is same as female, mean age of 40. Perhaps a little higher than that in the overall surveys of them. Most intraosseous, although, as I said to you, the Čerkanović and Gomez series found higher than that, and more in the mandible. So let's have a look at the classic CEOT, which essentially is what Pindborg initially described with a bit more detail and biological understanding. And then we'll talk about some of the minor variations of that before we start talking about the variants of CEOT. So in their development, we know that when they occur as very early lesions, CEOTs are largely radiolucent. And you can see in this OPT, or a section of an OPT, that there is a radiolucency between the perhaps what is the lower 7 and 5. The calcified component in many of these early lesions can be very difficult to detect, and they are also very often poorly outlined. They are certainly not corticated, and very often they're very poorly demarcated indeed. Here is a lesion which we had through our diagnostic service a little while ago, and you can see quite a large lesion in this case. And this is a more advanced point of its natural history. And you can see that it is a little more well-defined, and in fact, it's corticated in areas. It has, as many of them are associated with, a certain amount of calcification within it. It is now tending towards being a mixed radiodensity lesion. And there is the association of an unerupted tooth, which is present in about 50% of cases. In this case, you can see that there is some downward displacement of that unerupted third molar tooth. There is also present, and particularly most notable, on the distal aspect of the root of the mandibular second premolar, some amount of root resorption. And this is a radiograph which I inherited, which is, some of you may have a better radiograph of a large and expansile lesion. This is getting towards the sort of end point of the natural history when advanced lesions, this is a lateral oblique radiograph. It's not a wonderful radiograph, but it does demonstrate a large, destructive, mixed radiodensity lesion in the mandible, in which the calcified component is obviously quite extensive. And again, it tends to be quite poorly demarcated. It looks in this case as if the lower border of the mandible is really not discernible, such has been the level of destruction with the lesion. There have been some papers which have discussed at some detail the sectional imaging appearances of CEOT, and this is taken from a paper which was published almost now 21 years ago, looking at this. You can see on CT scan on the left-hand picture that it is a relatively well-defined lesion. It seems to be perhaps still contained, in this case, within the periosteum of the mandible, although it is quite expanded. There is cortical thinning in areas. There is a worrying look on the lingual side of the mandible, and we know that's an area of concern for large ameloblastomas as well. And overall, there is calcification within it, which gives it an overall a rather multilocular looking appearance. When you have a look at it on an MRI scan, here we can see that you can see the soft tissue component of that being highlighted, and it tends to have high signal on T2 weighted scans and low signal on T1 weighted scans. So the main histological appearances of the classic CEOT are very much as Pindborg had described. And here we see a very nice example of that, which with polyhedral cells, a copious amount of eosinophilic cytoplasm, very obvious cell boundaries. In many cases, you can see that the prickles are really very well formed in this case, so there's clear desmosomal attachment of these cells to each other. There can be marked nuclear variation. That's present to some extent in this case, but there are much more marked examples of that, which I will show you. And then in the background there, in between all of these cells, there are deposits of a homogeneous substance, which is amyloid, which then over a period of time will become calcified. So here's a larger section of a CEOT, which we had through the diagnostic service. You can see quite a very generous biopsy, and you get an idea that in fact down to the bottom right hand there is a certain amount of bone, and you can see that within the spaces between the bone that there is tumor extending into them. So it has that infiltrative pattern that we would see in ameloblastoma, in the fact that it will work its way through the cancellous spaces in the bone in addition to being destructive. The lesion itself here, as you can see, has got islands of epithelium, but also islands of calcification. And we're going to have a look at some of this case in a little higher power later on. Here we do see these islands of epithelium. They have this amorphous material, which is very closely associated with them, and then areas of calcification which are present. Here we have another example of the classic histological appearance. Now we're beginning to see a little more variation in nuclear shape and size of these cells. And very obviously the droplets of amyloid-like material in the background. Again, another example of a classic CEOT. Here we have the islands which are relatively well formed. We're beginning to see quite marked variation again in the nuclear shape and size. But things which we see, obviously this is something which might raise the possibility for an inexperienced eye of malignancy, but you will not find, or you'll be with great difficulty, you will find any mitosis. Again, a slightly higher power, showing that classic epithelial. In this case, a lot of the amyloid droplets have become calcified, some of which have this concentric calcification, very much looking like Liesegang rings. This will extend up to the surface of the bone, as you can see here. It's got a very obvious osteoblastic reaction to it. And this is the most profound example of the pleomorphism that we get in a CEOT that I found. This is in a case, in fact, from many, many years ago, which I dug out of our archive. And you can see extraordinary nuclear pleomorphism in a case like this. There are kind of horse-shaped nuclei, and so on, but not a mitosis in sight. And what gives rise to this extent of nuclear pleomorphism is not yet fully understood in these tumors, but it's something that is well recognized, and you may find examples like this, or perhaps even more extreme, as you see many cases. So that's the classic form with these large polyhedral cells, and there are some variations on that. Some of them, these say, are very cellular. And you can see in this case here that rather than being small islands separated by large amounts of amyloid and fibrous connective tissue, this is small amounts of amyloid, some calcification, but larger sheets of cells. And again, you can see here's another example of very similar, which is very cellular. And these small calcifications of the amyloid you can see scattered throughout this, but there's very little connective tissue and only a very small amount of amyloid that you can actually identify within this section. On the other hand, at the other extreme, there are those of which the epithelial component is very small indeed, and in fact then they are then dominated by amyloid, as in this case. The vast majority of what you're seeing in the background here is not actually collagen, it is deposits of amyloid. And there are some very fine strands of epithelium, as you can see, which are scattered throughout this. So given the histological variability that we see in CEOT, there was a suggestion way back, we're talking now the best part of 40 years ago, in a paper in Journal of Oral Pathology and Medicine in 1982, looking at separating these tumors into various different types, the different subtypes. And the paper by I. Ru et al., which, to be honest, has only been based upon 9 different tumors, which is something which has not then been tested in a larger cohort, suggested separation into 4 patterns. I think this probably doesn't have enough weight from the literature to carry it through, but nonetheless, it raises some interesting questions, with pattern 1 being the true classic that we know, we've seen very well, and I've shown you examples of. Pattern 2, some of them which are a little more cribriform in appearance. Again, you could probably take one of the examples that I showed you to fit into pattern 2. Pattern 3, particularly the cell dense variety, is, again, I've shown you an example of that. And pattern 4, I have also shown you in that. Although I think pattern 4 is something which I'm going to come back to talk about in a bit more detail, particularly when the tumors are composed of cords of cells with a collagenous background and not really very much in the way of an amyloid background. So others, there was a more recent paper suggesting we split them into epithelial rich, amyloid rich, calcification rich, and so on. So what about the amyloid? A very interesting part of that. And the tumours will vary very much in their amyloid content. Some will have a lot and some will not. And you can see a nice example here of this droplet deposit of amyloid in amongst the epithelial component. Some are very amyloid rich. And here's another example of one in which the epithelial component is present, but it's fairly well compressed, and the vast majority of the tumour is consisting of amyloid protein deposition. It will vary in its appearance, and we've seen some which are more droplet shaped. And at the top of this picture, you can see them, the droplet shaped amyloid deposits become calcified, whereas at the bottom here, this is large confluent masses of amyloid. We know that it is Congo or Sirius red positive. You can see a nice example here of that without any polarization, very obviously Congo red positive in the deposits of amyloid in this CEOT. And then when we have a look at it under polarized light, we get the apple green bifringence, which is present here, which is characteristic of amyloid. This is, I've put this in just to show an example of the calcification that you get of the amyloid. It's progressive, and it tends to occur in the larger masses in a sort of droplet form, like you can see here. But eventually masses like this will become confluent. And in fact, this actually accentuates the appearance. It's a PAS stain, and some of the amyloid, particularly that which is undergoing calcification, is PAS positive. So what is the amyloid material? Well, over the years, there have been many suggestions, and there has been a lot of work which has been done at ultrastructural level to try and identify this. It stands for amyloid A. So you can do that by immunohistochemistry if you're that way minded to do so. But the paper by Murphy, which is now, I guess, over 10 years old, showed that the amyloid protein, which is in CEOTs, was from the N-terminus of this protein called ODAM, odontogenic amyloblast associated protein. And they had mapped that onto a particular section of that protein, and generally speaking, it was of the order of about 153 amino acids. And the amyloid, which was being laid down in CEOTs, was pretty uniform like this. Calcification, as we said, is another classic feature that can be very extensive. All the way from these small calcifications that we've seen through to, for example, this case where there is extensive sheets of calcification of the amyloid as it's laid down. Another example of a bit higher power, again, of these droplets of calcification with the concentric least again ring appearance, and then the other more almost dystrophic looking appearance to the calcification. Here we have another example. This is one of the examples of the solid CEOT, in which I showed you a field in which there was very little amyloid and calcification. But in fact, when you move to a site at the edge of the specimen, you can see the amyloid present here and the extensive calcification which is present in this case as well. So that's our classic CEOT. There is a certain extent of morphological variability in that. Some people have tried to put them into various subgroups, and the amyloid and the calcification. So what about the histogenesis of these tumours? Where do they come from? Well, that is disputed and is by no means agreed. There are a number of theories in that. The dental lamina theory, which particularly relates to those extraosseous or the peripheral CEOTs, has been talked about in some papers. And I don't think there is any real evidence for that other than the fact that it is felt likely that those odontogenic tumours which arise in the soft tissues outside the bone of the jaw are likely to come from dental lamina. I have not gathered any direct evidence to support that. Interestingly, in the Franklin and Pindborg paper in 1976, they mentioned that there was some suggestion that there was morphological similarity of the cells, these polyhedral cells, with stratum intermedium cells. Now, hopefully you will remember stratum intermedium. If you remember back to your developing tooth, in the enamel epithelium, which is laying down the enamel, there is the inner enamel epithelium that these cells become elongated when they are secretory, the Tome's processes and so on. But just deep to that are a group of cells which are responsible for, to some extent, controlling the activity of the ameloblasts, but also regulating elements of calcification as the developing enamel becomes mineralized. And these are there present transiently during the formation of the tooth. And there was some suggestion that they may be related to that. Now, we have had a look in Sheffield at some of the suggested specific markers of stratum intermedium and had a look at them in a number of CEOTs, and I'm not entirely convinced by that. But that is something which, as we go on and we're able to perhaps to more clearly microdissect out various components, perhaps of developing tooth germs, and we can understand the basic biology of some of these cell types, there may be more understanding to be gained from that. Now, what about the immunophenotype of these cells? If you use immunohistochemistry, what would you find? There's a lot in common with all the other odontogenic tumours. In the Azevedo paper from 2013, they showed expression of cytokeratin. Cytokeratin 19 is present in a lot of odontogenic tumours. It's not sensitive or specific for it, but it can be quite helpful. And other markers as well. Amyloid A, as I've already indicated, is present. A few years earlier, there were a more extensive range of immunohistochemistry which was undertaken. Cytokeratin 5 positive again, p63 calponin, which is interesting, and other markers such as smooth muscle actin, S100 and GFAP all being negative. Variable staining of vimentin and CD10, where CD10 perhaps has been done in the context more of the clear cell variants, which I'm going to come back to talk a little bit about later. So overall, the immunophenotype is perhaps not particularly helpful. And here's some of the work that we've done ourselves on one of or two of our CEOTs. Pancytokeratin A1, A3 positive, quite diffusely positive for cytokeratin 14. And we have certainly found in a number of our cases that the expression of cytokeratin 19 can be quite variable, with some areas expressing cytokeratin 19 and other areas not expressing. As far as proliferation is concerned, looking at the proliferation fraction using Chi67, we had this group of 8 CEOTs, which were from our local area over the period of looking at them when Samadara was with us. And we did some immunohistochemistry on that, and this immunohistochemistry was undertaken by one of our master's students a number of years ago. And it showed that, in fact, the proliferation fraction was relatively low. There was 1 or 2 tumours which were about 5%, but the others had a proliferation fraction assessed by using Chi67, which was really very low, very similar in many ways to that variety of Chi67 expression you see in ameloblastoma. Very interesting when you start looking at some of the more ameloblast-specific proteins. This is amelogenin. And we've certainly found that amelogenin is expressed in our group of CEOTs. You can see here in both those which have just got amyloid scattered around and no calcification, and this one on the bottom here, which has got calcification, that there is expression of ameloblast type proteins. And again, it probably does indicate that to some extent these tumours are developing from probably something in relation to the inner enamel epithelium. What about molecular pathology? Now, this is now very much in its infancy in terms of CEOT, and there's not very much out there. P-patch mutations have been looked at. A couple of mutations found in cases nobody is really aware what the significance is. AMB, I think it's ameloblastin mutations. And in others, there's been, I think, D'Souza's group, Susanna D'Souza in Sao Paulo, having had a look at sequencing of common cancer genes in CEOTs, and again, finding single nucleotide variations, a number of mutations, but The mutations were relatively rare, one case each, and there was no recurrent driver mutations present in CEOT. So the overall molecular background and molecular profiling, particularly looking for genetic changes which might drive the formation of these tumours, has still not come up with anything which is consistent. So then we come to the point where CEOT begins to become a bit complicated, and because we're really now we've gone to molecular pathology, which is now pretty much up to date, but we really need to then start going back into the earlier part of the literature again, where we found that there were varieties of, or different variants were being described, things which didn't quite fit with the classic description of the CEOT. And so these variants include the peripheral variant, clear cell variant, what I would probably term the Langerhans cell-rich variant, the cystic and microcystic variant, which is a much more recent description, and then combined AOT, CEOT. So what about peripheral CEOT? And these are lesions which arise within the gingiva. They are developing in the tissues out with the confines of the jaws. And these account for at least 7% of CEOTs, although as I showed you in the Cherkanovich and Gomez survey, they found far more than that. Mostly they are in the anterior maxilla. Here you can actually see in this radiograph from a case report in 2009, it's a mandibular lesion, and in fact it looks as if there may well be more than one. And in fact, it is an anatomical variant rather than a histological variant, because the variants, the histological variants, and the range of them has also been described within peripheral lesions. And very often, the peripheral lesions have very minimal or no calcification. The clear cell variant is very interesting, and there has been a lot of reports in the literature. And we're talking about Pindborg's original description in 1958. The clear cell variant started to be reported in the literature about 10 years later or so. And there are 30 documented cases in the literature, and I think there are probably, very many more of these which are unreported. In the 30 cases which are reported in the literature, there are 21 which are central and 9 peripheral. The age range is very similar, with a mean age very similar to the classic type. 30 cases turns out as 13 male, 17 female, although it's probably not a large enough survey to say that there would be a female predominance. But there does seem to be a difference in the ages of those who have the intraoral version, those with the intraosseous rather than extraosseous variants. Some reports have suggested increased aggressiveness, but this is not borne out across all of the cases which have been described. So what about the histological features? Well, in many cases of clear cell CEOT, there are areas of conventional CEOT, classic CEOT, with the more classic histological appearance of the cells, with amyloid and with calcification. And so that is a caveat to bear in mind. If you're looking at something and you think that this well could be a clear cell CEOT, you should be able to find something which is more characteristic in that. If it is not present, well then it may well push you towards at least working through the differential diagnosis, because it's a very important differential diagnosis for this lesion. As the name implies, there are a significant proportion of clear cells. Now, when you do a PES stain on that, you'll find that there is granular PES positivity, which disappears if you have pre-treatment with diastase. The Alcium blue negative, so there's no indication at all they're mucin. In fact, given the fact that they're PES positive diastase labile, they may well be a degenerative phenomenon in which what you're seeing is the accumulation of glycogen and then degeneration within the cells. And if you remember back to Pindborg's original description, he talked about a proportion of the cells, even in the classic CEOT, which had this appearance of intracellular degeneration. And so it's something which has been noted all the way back from the beginning. So here we come to an area, I've already actually shown this tumour. Another area of it was that very solid tumour, but this case, as you can see, particularly over on the right-hand side, even at low power, you can judge that there is quite a lot of cytoplasmic clearing in this cell. And there are islands, in fact, of cells which have relatively clear cytoplasm. Some of them are very clear indeed. And you can see in this case here that, in fact, all of the cells have cytoplasmic clearing. They look very similar actually in their overall shape to classic CEOTs. They are polyhedral cells with very obvious nucleus. So here's our PAS and DPAS. The PAS itself, you see, have to look carefully. It's not a uniform PES staining across the whole of the cytoplasm. It is granular PES staining across the cytoplasm, which then, if you were to pre-treat with diastase, there is no staining in the epithelial cells at all. Here's a closer example of that granular PES staining that you'll find in the background. There's a little bit of pickup on the amyloid as well. And so that does bring me to the differential diagnosis of clear cell lesions of the jaws. Now, this is something I'm sure that any of you who've got any background in oral pathology will be very well aware of, and the circumstances in which this differential diagnosis has to be worked through. And so when you come to think that you've got something which is a clear cell CEOT, and particularly if you're struggling to find areas which have classic features, you do have to take these into account. And these include a clear cell odontogenic carcinoma and metastatic carcinomas with clear cells. So that includes renal cell carcinoma, and then salivary gland clear cell carcinoma, and also to a certain extent mucoepidermoid carcinoma. But there are also other metastatic lesions which may present with clear cells. And in these cases, it is important to systematically go through a workup, and using a PAS and DPAS, that may well be helpful. For example, if it's a clear cell mucoepidermoid carcinoma, you may well identify mucous cells. Immunohistochemistry, very important. Renal cell carcinoma, antigen RCC, and CD10 can be very useful for identifying renal cell carcinomas. But at times, you may also require help from cytogenetics in also to identify or to separate some of these lesions from each other. And this then brings us to Liz Bilodeau's paper, which was now published a few years ago, looking at this whole area of the clear cell lesions of the jaws and how we distinguish them. And she noted, in having a look at a number of clear cell lesions from within the jaws, that cytogenetic analysis of EWSR1 rearrangements was very helpful. Again, if you're aware of the ongoing development of cytogenetic tests, I'm sure you will be aware that EWSR1 rearrangements are actually very common in a wide range of different tumours. One of the groups of tumours in which they are present are clear cell carcinomas. And here she has shown that clear cell odontogenic carcinomas and clear cell carcinomas in general harbour EWSR1 rearrangements. So the clear cell carcinomas had come from other cases, salivary gland and so on. And the clear cell odontogenic carcinoma, there was 5 of them. There was 5 of them were positive, 1 which was negative. The ones which failed, some of them were reassessed, and it was thought that perhaps they were better assessed as clear cell odontogenic, clear cell CEOTs, and of which none of them had an EWSR1 rearrangement. And so if you're struggling with that whole idea of, is this a clear cell variant of a CEOT, or is it a clear cell odontogenic carcinoma, then using EWSR1 rearrangements cytogenetic, you can do that by FISH. It may or may not be available to you to do. We certainly have a local genomics facility who can do this for us, and that can be very useful. Now we come to the non-calcifying variant, and this is certainly in terms of the literature the least common variant, and I think there may well be reasons for that which are down to the definitions that we might use. It is a lesion which is controversial, and I'm going to talk about that. It may be intraosseous or osseous. It has a lack of calcification. Some have suggested that, in fact, it may be actually just age-related. If you're to leave these lesions long enough, they would calcify. And most of these, in terms of their overall description, fit with that IRU type 4, which I showed you in the schematic earlier, of the 4 different subtypes which have been suggested. And interestingly, most contain Langerhans cells. So here's an example of one such lesion, which you can see that there is, it's very difficult actually from this one section to make a diagnosis of a CEOT. There are islands and strands of odontogenic epithelium. And the background doesn't really contain very much in the way of amyloid, and it's largely collagenous. And there's no hint of any calcification at all. Now, this does bring you to an interesting concept. When Paul Spate and I were rewriting the chapter for the most recent version of Fletcher's, the copy editor really didn't have very many comments to make on the text that we had written. But one that he did comment upon was our use of the term of a non-calcifying, calcifying epithelial odontogenic tumour, which of course is a complete contradiction in terms. How can you have a non-calcifying variant of a calcifying tumour? And you know, it's one of the, we do, I guess, in pathology sometimes sit with these oxymorons and just we accept them. But I think it's probably telling us something about these lesions that does require us to spend a bit more time seeing, does it actually fit into the group of CEOT variants? And particularly the fact that it's been shown that these contain a large number of Langerhans cells. These, as you're very well aware, are dendritic antigen presenting cells that are S100 and CD1A positive. And so there are a number of case reports of these, particularly originally they were all in Asian patients, but that's not the case now. I think there's been a case in an African patient and also a case in a Mexican patient. And these lesions are non-calcified. The significance of them is unclear, and we don't really know to some extent what these are. So here's a couple of examples. There's a lesion, as you can see here, in mandible. The H&E is present here. You can see the islands of epithelium. Looks as if there might be a little bit of amyloid here, but it's not an extensive feature, but there is some amyloid present. And there are Langerhans cells, the CD1A stain, scattered throughout the epithelium. And similarly, on this other case here, you can see there's a lesion which looks as if it's quite a large destructive lesion in the maxilla. They're tiny little strands of epithelium. And again, these also contain Langerhans cells amongst them. So it raises a question, well, given the fact that it doesn't have any calcification, are these lesions actually CEOTs at all? And I wonder whether many of you read the papers by Professor Fumio Aide. I find them fascinating papers. He is very thoughtful in the way that he approaches them and is often very controversial. And there was a paper which was published in Head and Neck Pathology in 2019. And this was reviewing this whole concept of non-calcifying CEOTs. And I commend you to have a look at this paper and read it if you have the time to do so. And he's making the point that, in fact, there's not a lot of support either from a histological appearance or from a molecular appearance that these lesions actually are CEOTs at all. And then if you have a look back into the literature, back into Roy Eversole's work, looking at odontogenic fibromas, and particularly the amyloid-rich variant of these, and we've been having a look at some of these lesions, the odontogenic fibromas with the Brazilian group. There's been a collaboration looking at some of these recently, and published a paper in OOO that I was involved with. It perhaps fits far better with them, not only from a histological point of view, but probably from a biological point of view as well. And so it may be that, in fact, we've allowed the classification of CEOTs just to get a life of its own. And in fact, we've overstepped into areas which there's significant overlap with other odontogenic tumours. And it might require some thought as to how we then redefine or define the boundaries much more clearly in relation to the classification of these tumours. So this actually is back to Roy Eversole's paper. He published a series of 65 odontogenic fibromas. 4 of them contained amyloid, molecularly of the same type as we're getting in CEOTs, but also Langerhans cell, all in the maxilla. And he pointed out the overlap of these with odontogenic fibroma. And the WHO classification in 1972, in fact, acknowledges that, but it never really was picked up into the development of the classification subsequently. Recently, there have been a number of what we call cystic or microcystic cases, which have been described. These obviously the microcysts, small cases, the large cysts, they can be really quite predominantly cystic. And whilst we have these 5 cases which have been reported, the natural history of them and how they behave has not yet really been established. And then lastly, we come to the so-called combined CEOT and AEOT. And this, as many of you have got significant experience in odontogenic tumour histology, will know that in fact, you can relatively frequently find CEOT-like areas in many AOTs. And I think this is now quite convincingly been resolved that in fact this is not a specific feature and it is not a variant of CEOT. And in fact, these are lesions which are within the overall spectrum of AOTs and really shouldn't be viewed as a variant of CEOT. So bringing things back together, I guess, for a bit more discursive, which we might actually focus then into some discussion on this tumour, this very interesting tumour, is that we do have some ongoing areas of difficulty. And these continue to be CEOT, particularly clear cell CEOT and the differential diagnosis of clear cell odontogenic carcinoma. We still have this question of, are the non-calcifying Langerhans cell rich lesions CEOTs at all? And do we have to redefine some of the boundaries in the classification? And then there are a number of lesions which I've not really talked about. And certainly I know that Roman Carlos particularly has an interest in these lesions which contain significant calcification, sometimes described as dentinoid. You know, do these form part of the spectrum of CEOTs, or are we needing to have another item in the classification to deal with these lesions with dentinoid? I think we probably are, but that's a discussion for another day. And then there are some more unusual odontogenic tumours with CEOT features and how we classify them. The classification, I think, these unusual ones, which include the odontogenic carcinoma with dentinoid, and the next lecture I had planned this as part of a series with malignant odontogenic tumours, so that's not going to follow. You're not going to have to suffer another lecture from me. I'm sure you'll be glad about that. But there are others really are very difficult to classify, and at times I feel with these lesions we are trying to hammer a square peg into a round hole. They don't quite fit. And perhaps it needs time just to take a step back and have a look at the classifications to see how that might do. And it's going to be very interesting to see how the next classification comes, because I think we might be seeing that, as far as I'm aware, by the middle of this year. What about the Sheffield experience? Well, I've gone to this. We reviewed our 27 CEOTs over a long period of time. Most of them, as I indicated, were referral cases, and they were very similar in their demographics to that which has been described in the literature. And we found that, in fact, there was a good proportion of them had clear cells in them and had calcification. And we came to the conclusion that, in fact, a lot of the diagnosis of these as CEOTs had really gone along with the way the classification had been developing at that time. And when Paul and Ali and I sat and had a look at a lot of these, we wondered if, in fact, there was a significant proportion of them whether we would actually still call them CEOTs, particularly with the ongoing development of and the appearance of clear cell odontogenic carcinoma, the suggestion of odontogenic carcinoma with dentinoid, and so on. And so this was our 27 lesions. You can actually see the full list of them if you go and read the paper that we published in Head and Neck Pathology last year. And in fact, you can see, particularly in the right-hand column there, it was only probably about half of them that we were absolutely convinced were CEOTs. There was some evidence in some of them that certainly posed the diagnosis into doubt. But that's just the way that diagnosis goes and develops along with a developing classification at the time. So where are we now? Well, I think we have the classics. There are those which are incontrovertibly CEOTs, very beautiful to look at histologically. We do have some variants. It's in the center picture there, where we know that there's enough to tell us that they definitely are CEOTs, but there is variation. There may be variation in their cellularity, maybe variation in the amount of amyloid or calcification that they've got. They may be clear cell, but they will perhaps have some classic areas to them, but they are very definitely variants of CEOT. And then, unfortunately, as is very often the case in pathology and classifications, we have the bucket, in which goes everything else. Where there's been a suggestion that it might be a CEOT or it's got some CEOT features. And into them probably goes a wide range of lesions, which perhaps as our understanding of the molecular basis of odontogenic tumors progresses, we might find that some of them fit into existing other classifications, or items in the classification, or in fact into new variants themselves. So I was wondering, and I posed the question, and we posed the question in the paper that we published last year, is it time to a certain extent for a rethink of the classification of CEOT? And should we then be to some extent dialing back towards these more classically described features, and only those which are the variants in which we know there is very good evidence that they are CEOTs? Perhaps we should be looking at the non-calcifying Langerhans cell-rich lesions being formally classified along with the odontogenic fibroma. And I think that's an interesting ongoing discussion to have. How much do we need cytogenetics? Are there going to be other cytogenetic markers which will define other lesions that may be used? And we don't use EWSR1 studies very often, but on occasion they are very helpful. And then, of course, that question which I've raised, what about dentinoid or cementum-like material? Where does it fit into the spectrum of appearances of this lesion? So as far as I'm just throwing out some ideas now in terms of how we might address this, do we need to have some sort of consensus on diagnostic criteria, whether we would find that we would actually get consensus in tumors where there are particularly areas of controversy can be quite difficult. And we'll have seen that, for example, in the whole idea of ameloblastic fibroodontome and developing odontome in the last classification and so on. We probably do need genomic analysis of a good-sized cohort, both of the classic cases and the variants, and that will allow us to see whether there are any consistent changes which would be helpful for diagnosis. And I think that this can probably only be done as an international consortium in collecting cases with a good background of clinical, radiographic, histological material that will allow us to be able to assess these lesions well. So I do now open this for discussion, and perhaps we'll come to the questions. I'm very much realized that in coming to talk to you all today, this is not, I am standing on the shoulders of a lot of very great oral pathologists. I've quoted a lot of different papers from people who have far higher standing in the oral pathology community than I can ever hope to have. But in particular, there are a few people I want to thank who have encouraged my love of odontogenic tumors over the years. And these are people who you see at the bottom here, who many of you will know very well. I'm particularly indebted to the man on the bottom left, who is now long gone from us. That's Professor Gordon MacDonald, who was my initial trainer in Glasgow. And I am very much indebted to him for my love of all things oral pathology. And he's someone that I still quote and to be honest, miss very much now that he's gone. Paul, many of you know as well, and has been my mentor in Sheffield for many years, up until his retirement a couple of years ago, and I'm very grateful for his help and encouragement and support. And similarly, John Wright, I had the privilege of spending a summer in the department with John many years ago, which was very helpful in sorting out a whole number of my different concepts, particularly in odontogenic tumours. And related to that, obviously, Bill Binney, who played a very important role in my training. After Gordon MacDonald's passing, Bill had returned to Scotland at that point, and he spent many hours, which he didn't need to do with me, just helping me finish off my training. I'm also going to be very indebted to him. Obviously, he has now passed on as well, and he is also missed. Roman Carlos can be, Roman is one of these people who always provokes you to think. And again, Roman's papers are very thoughtful, and the interactions I've had and his encouragement. Similarly with Eddie, with his love of odontogenic tumours, and Ricardo and Carolina in Belo Horizonte, and the molecular work that's going on and the collaborations that we have with them, I'm also once again really very much indebted. And that at the moment is all that I have to say. And I'm going to stop sharing my screen, and we can then move on to the moderation and the questions.
Thank you, Professor Keith. That was wonderful. That seeing your, I have seen the paper, but the pictures look even nicer here, I must say somehow. And the description was very good. Thank you so much. And I don't know if you have noticed, but among us now we have a number of experts from around the world. So perhaps at the end you can have your discussion as you were hoping. But first, I think we will just open it to questions. Dr. Selvi, can you take that, please?
Yeah, thank you, Dr. Keith. It was wonderful presentation. You have covered almost all the aspects of CEOT, beginning from the beginning to at present. So while we have received few questions in the by email, one of the questions is from Osmani Guerra, Ecuador. So he wants to know what would you consider CEOT? Whether you would consider it as benign, malignant, mixed, or as hybrid tumor?
That's a very interesting question. And of course, the one thing which I haven't even mentioned at all is the whole concept of malignancy.
Yes.
There are some very good leads, and I've seen some of them certainly in slide sets that we've had in the UK of tumours with very much CEOT features, but also cytological features of malignancy. I think that the whole concept of the terminology that we use in terms of benign and malignant for odontogenic tumours is quite difficult, because these are lesions which we know that, as I would say, they don't metastasize, of course. Well, then somebody's going to say, well, you get malignant ameloblastomas, metastasizing ameloblastomas, but they are infiltrative and destructive tumours. Yet we still do insist on referring to them as benign but locally aggressive tumours. And when I'm teaching my undergraduates, these tend to be the terms that I use that, you know, strictly speaking by the classification, they are benign, but they are locally destructive lesions. And I think with Eddie years ago, I think after a BSOMP with Eddie Odell, we did have a discussion of, you know, whether given the aggressiveness of some of these lesions, whether terms which are applied in other areas of pathology, which should talk about lesions of intermediate lesions, whether these are terms that actually might be useful to be used to some extent in terms of odontogenic tumours. But I think that, in my experience, muddying the waters between benign and malignant tends to bring confusion rather than clarity. And so I still do tend to refer to CEOTs as benign. And if there was anything in which I saw that there was incontrovertible appearances which were suggesting cytological malignancy, of course, we're talking about then things like necrosis, mitosis, abnormal mitosis, and so on, I would then use the term malignant. But I don't think that I'm currently in favor in terms of trying to put sort of intermediate malignancy type terminology into odontogenic tumours. But I'd be very interested to hear what others such as Tilak or Merva or Raghu have to say about that.
Yes, sir, please.
Unmute
Dr. Tilakratne, please unmute yourself. You might as well chip in right now itself.
No, Keith, that was a very good lecture. Because I think if the trainees were listening, I think they must have got everything what is needed in CEOT. We know a lot of things about CEOT compared to our training days. Actually, when Keith showed Gordon MacDonald's picture, I became a little sensitive as well, because he was my examiner for Part 1 MRCPAT in your dental school in Glasgow. I totally agree with Keith. You know, some of these odontogenic tumors at the moment in the benign category, if you compare with the rest of the body, you know, have the attributes of naming as intermediate malignancies. But I think we are far away from that. Even for the coming WHO classification, hopefully it will be ready by end of the year. So still, we don't expect any drastic changes in that area. As it is now, I think we need to consider CEOT is a benign tumor. And what is interesting is, Keith, to look at, because we don't have enough cases, whether different histological variants have something in terms of, you know, the behavior changes. Because unless you know that is there, you know, people do not take these things into much of consideration. It is interesting for us, but it's more like academic interest. But you correctly pointed out, you know, some of these COTs, the clear cell variants, maybe clear cell odontogenic carcinomas, at least it's a good differential. If you remember, up to late 90s, we call clear cell odontogenic carcinoma as clear cell odontogenic tumor. We were not sure whether it is malignant or benign, but now we know the spectrum of clear cell odontogenic carcinoma. One end of the spectrum is more benign looking, and the other end of the spectrum, very nasty malignancies going to lymph nodes and, you know, even kill the patient. So, as Keith correctly raised, I think some of these clear cell, calcifying epithelial odontogenic tumors that we diagnosed in the past may be the lower spectrum of clear cell odontogenic carcinomas. But my suggestion, Keith, because you have a great interest in odontogenic tumors, and people will realize that with new classification more, I'm sure you will give very good in-depth knowledge on CEOT in the new the edition. But more importantly, I think for us to get a better understanding about most of the odontogenic tumors, especially rare ones that we don't have much idea on, even at the amyloblastic fibrodontoma and amyloblastic fibrodentinoma, the huge argument now these days, we have done enough extensive search, Eddie, myself, and Susan, but still we are at the same place. So therefore, can I suggest, Keith, for us to start a big international consortium, getting some very leading big oral pathology centers around the globe. So I will certainly help you to get the help from all the pathology departments, big ones in Asia. Then we perhaps can have a huge number of cases. We perhaps don't need common things like amyloblastoma, but the other tumors. I'm sure we have not understood most of the aspects of a lot of these things. So I will put forward that as the proposal. Keith, if you can think about this and prepare some kind of a proposal, because we don't need much money for this. It is a matter of mostly even histopathological. So what do you think about it, Keith?
I think that would be a very good idea. I'd be very supportive of that. So, perhaps you and I together can work up at least a list of initial people that we should approach and just a few aims and objectives for that and just see what kind of response that we get. I agree. I don't think we really need to do it for things like amyloblastoma. There's a lot of ongoing research with that, but it's more some of the collecting, getting good material from some of the rarer tumors, and that then would allow us to be able to do. I mean, fullness of time, we probably would need a little bit of money because we would want to do a little bit of genomic work on these tumors. But nonetheless, to get a good collection to begin with would be something which would be a very low cost indeed. So I think that would be something that would be very useful. I'd be very supportive of that.
Moving on to second question. It is from Abhinashi. Is there any particular reason for concentric calcification of amyloid material? Does the same concept apply for the keratin pearls in oral squamous cell carcinoma?
I'm not sure that if anybody really knows the classification, and you could see that it's almost. I showed that picture of the PAS stain where there was the beginning of the calcification, and you could see it almost reminds me a bit of the calcospheric calcification of dentine, in terms of that focal starting and then it's building out round about that. And it may be that the calcification, because you get the rings, and it's obviously something which is happening at particular points of time, and then there's a stop because it's an optical phenomenon, so you're getting some laid down and then a stop and then a start again. So I don't know, and it might, the whole thing about the way that the calcification might be regulated, and whether if these cells are stratum intermedium cells, that they are to some extent processing the amount of calcification that's available then to the amyloid. I just don't know, but there are so many different fascinating questions that you could potentially answer if you could actually, just it'd be wonderful to actually get some of these cells to grow in a lab, and you could actually then do some of these experiments and look at calcium flux across. Once you start thinking about it, the list of experiments that you could do in that will be absolutely endless.
Thank you, Doctor. There's one question. What would be the pathological and clinical criteria to treat this tumor? Do you have any criteria?
I guess in terms of treatment, and that's something I suppose I've not really talked about, the overall scheme that people tend to follow is that the way that the more aggressive benign odontogenic tumors are. So we're talking here about ameloblastoma, odontogenic myxoma, and CEOT, which are the three kind of classic locally aggressive benign odontogenic tumors, and they are all treated largely the same way. I would say that it's not appropriate for CEOT, as it wouldn't be necessarily for ameloblastoma or for myxoma, to primarily be treating these by enucleation. You're going to end up with far too much in terms of recurrence, because I have a lot of ongoing discussions, as Tilak will probably be aware, with Mark McGurk about whether we actually overtreat ameloblastomas, but that's a discussion for another day. So my view in terms of that would be that a diagnosis of a CEOT essentially is meaning that we're looking at doing some form of resection, probably a segmental excision. Much more straightforward in the mandible, as you're probably well aware, can be very difficult to get clearance in the maxilla for the anatomical reasons that we know. So nothing really beyond the fact, if you have an established diagnosis, that these lesions are, from a treatment point of view, looked at very similarly to significant sized ameloblastomas and odontogenic myxomas.
Thank you, Doctor. So what is your experience of recurrence among your series of cases, Doctor?
We have had, from our own cases, we have 8 local cases. The definitive treatment on them was all done by resection, and none of them have recurred.
Thank you.
Of the 27 that we have overall, of course, 19 or 20 of them were referral cases, and I don't know the outcome of them. I think probably that the overall recurrence rate, which Cherkanovich and Gomez have said about 12%, will probably relate to a variability in the way that these lesions have been treated.
Thank you, Doctor. So you talked about the variants of CEOT. So there is an article in literature discussing about dental follicle associated CEOT areas. What is your take on that?
Yeah, these are interesting, and these seem to these come up in discussion quite a lot, and I think that the body of the literature, and I think probably my opinion of them, is that these appearances, which are occurring within the dental follicle, are largely probably still within the same spectrum of lesions which we look at AOT, the CEOT areas in AOT, the CEOT areas within the follicle. And whilst I guess there might be some of these lesions, because we know that 50% of CEOTs develop and associated with an unerupted tooth, if left in fullness of time, might develop into CEOTs. I think the weight of the literature is still undecided on that, and it may well be that there is a proportion of them are going to be part of that AOT hamartoma type appearance, and then some of them, I just don't think we know enough about the natural history of CEOT to be definitive on that, but they're very well described in the literature.
Yes. So is there any way to find out whether these dental follicle associated CEOTs can be precursors to CEOTs? Can we do some immunohistochemistry test or some?
That I don't know, and I need to give that some thought. The only way to prove if something is a precursor is to leave it to grow into the lesion. That's the only way to prove it, and of course that would be completely unethical. And many of these lesions, of course, are that you get. You're not looking at any radiographic lesion. These are probably dentigerous cysts surrounding unerupted teeth, and the appearance of a CEOT area, or even at times AOT areas, they are particularly just that they are histological by chance. So it may be that if we manage to get an international consortium which then defines what the molecular signature of a CEOT is, in terms perhaps of some mutations, if we can do whole genome sequencing, or other areas of chromosomal rearrangement, again, if they happen to be present, and you can then apply that into these lesions. But we would need to get and to define what that is, what molecularly defines a CEOT, before you could then say, is a precursor of a CEOT? Is this lesion a precursor of a CEOT? So we're still, I think, a way away from being able to do that.
Thank you, doctor. That's a good idea. There is one question. I know you said you don't know, but Dr. Priya has asked why there is nuclear abnormalities though CEOT is considered benign.
That I don't know, and I would like to get some genomic material from these, because then you can have a look and you can see, okay, what is the basis of the hyperchromasia and the expansion of the nucleus? Is it the fact that are they commonly tetraploid, for example? Have they just copied their genome but with no other abnormality? And so it would be interesting to do some fairly simple techniques looking at chromosomal counts and so on, just to see, in a range of the lesions, from things, the ones which haven't got very much nuclear abnormality through to those which are very extreme. But as far as I'm aware, nobody has done that.
There's one question. You have talked about ODAM protein in amyloid material of CEOT. In literature, again, there are articles where they have discussed about ODAM protein in amyloid present in various carcinomas, especially carcinoma, gastric carcinoma, breast cancer carcinoma. So what is your take on that? Why is this protein being seen there?
Well, of course, what you've got to remember is where the names of proteins come from. And in very much, proteins tend to get their names initially from the point where they were first described. And this protein was initially described in relation to the development of teeth. And the proteins which are formed in relation to the matrix, which then becomes mineralized. But there are obviously proteins which actually have other biological functions as well. And so I don't know what the function of that protein might well be in the gastric mucosa, but I can only assume that it has some. And suppose it's really just because we've given it a name as an odontogenic associated thing doesn't mean that, oh, this is really strange, we're getting odontogenic type differentiation in gastric carcinomas. I don't think that's the case at all. It's a protein which is being aberrantly expressed for whatever reason, and it may well have a normal function elsewhere in the body. So I think that you probably come up with a number of examples of that.
There's one question from Dr. Arvind. Is it right time to simplify our odontogenic classification on basis of the treatment outcome?
Pardon, could you repeat the question, please?
Is it the right time to simplify our odontogenic classification on basis of the treatment outcome?
Now here we go into, we've had discussions, and again, one of the greatest protagonists of this type of discussion is the erstwhile previously mentioned Professor Mark McGurk, who generally would just, we have discussions at times, and I have with him and I have with other surgeons, to say, look, all I really want to know is to tell me, I just want you to tell me how it's going to behave and how much I have to chop out. I don't really interested in the finer points of whether you want to say that this is the XYZ subcategory 4 subpoint 3 variant of some particular tumor. Just tell me what to do with it. And I guess it's just a difference in worldview of these whole things. I being a pathologist, I tend to being a bit of a lumper and not a splitter, but I'm a pathologist, so I by nature have to be a bit of a splitter because I want to understand the biology. So my answer to that is no, I don't think we're just wanting to start lump things together in terms of how they all behave or what the treatment is. I think we lose a lot of underpinning scientific nuance and understanding of the biology if we do that. But again, there are others who may disagree with that.
Thank you, Professor Keith. I think we come to the end of the question round session. Dr. Raghu seems to be having some doubts. Yes, Dr.
I just want to say hi to Keith. Thank you, Mandana, for requesting me to co-host this. I mean, I know I have actually discussed this with Keith some time back. Is it time for us to actually consider the non-calcifying variant of CEOT, which is LC-rich, as an independent standalone entity instead of actually sub-classifying it or considering it as a variant of conventional COT?
Yeah,
because it's mostly seen among.
Yeah, I think there's a lot of
more amongst the Asians.
Yeah, there's a lot of evidence which I think indicates that it is not a CEOT.
That's right.
The question I think really is it something which is significantly has it got enough features to make it stand on its own? Is it significantly distinctive? Because if you read Roy Ebersol's paper, and I think it's a very interesting paper, although it's now quite old, I think there's a lot to commend the idea that in fact it's probably part of the spectrum of odontogenic fibroma, which I think is probably in many ways the least well understood and defined of any of the odontogenic tumors. I find that, as you look at the descriptions through the years of the WHO classifications, you sometimes wonder exactly what they're getting at with that lesion. And I've also spoken to some otopathologists who actually don't believe that it actually is a lesion, a defined entity in itself anyway. So it's a good question. I would think that there's probably insufficient evidence in the literature at the moment for it to be identified as a distinct entity in its own right. But of course, we know that things like the primordial odontogenic tumor ended up in the classification the last time on the basis of about half a dozen cases. But it did have distinctive histological features. So it's an open question, Raghu, it's a good one.
But the primordial odontogenic tumor, Mosquito was talking about it from the days that I know him.
Yeah.
You know, I think it goes back to about 20 years.
Mm-hmm.
I remember he was talking about that even the IOP meeting in Cape Town, if I remember.
Yeah. That's before I started training. That's a long time ago.
Yeah, when Paul was the secretary.
Yeah.
Yeah, you are right. But that is the thing that, you know, if we have a good collection to look at, you know, this, I'm sure we can extract some of the primordial odontogenic tumors if you look at, you know, the hyperplastic dental follicles, odontogenic myxomas, some of the developing odontomes. I'm sure some of those, the primordial odontogenic tumors are in that basket, I think.
Yeah.
Yeah, but
yeah, I agree.
But it is interesting. No sooner 2017 classification came, I looked at all the odontogenic myxomas in our department, a large number, but I couldn't find even a single.
Yeah.
You know, one of the things, Keith, that we could actually look at is because this non-calcifying variant of CEOT is predominantly seen amongst the Asians. And unlike the conventional CEOT, it occurs more in the anterior region. And again, Langerhans cells are primarily there because you have predominantly a lymphoplasmacytic infiltration in the cyst wall. And some of these Langerhans cells are also present in the ruptured lining of the epidermoid cyst and the dermoid cyst. So I was only thinking that if it is the odontogenic variant of the epidermoid cyst or the intraosseous variant of the dermoid cyst, and since it's not having any of the features that suggest that it is a CEOT, I was just thinking that it's time that we just consider this as a distinct entity than be regarded as a variant of CEOT.
Dr. Selvi, I think there's one more question. Have you got it there? From Dr. Puyan.
Dr. Puyan wanted to know about whether there is IHC to differentiate between clear cell variant of CEOT from clear cell odontogenic carcinoma.
No, not that I am aware of. I think the only way to consistently do that is to have a look for on cytogenetics. You know, and of course, in fact, that with some cytogenetic abnormalities, you get the production of a fusion protein. You know, for example, in that which you see in mucoepidermoid carcinomas. But very often, in fact, making the antibodies to the fusion proteins is very difficult. I'm digressing a little bit, but we've been looking at with Lynn Bengal in the department, looking at how the meched mammal antibodies perform in those that we know, these tumors, mucoepidermoids that have got the meched mammal fusion transcripts, and they're not very good. So there may well be changes in terms of proteins produced in the EWSR1 rearranged cells, but I'm not aware that anybody's using antibodies to look at them, because I just don't think that they're good enough, and it has to be done by fish, unfortunately.
But if you do a Chi-67, definitely there should be a difference between you know, the border.
Yes, that is true. And that, I suppose, is an indirect measure of your proliferation rate. And you know, we have Paul and I have published before with, I think, a lot of support from others in the literature that, you know, for example, once you get above about 20% in a lot of these odontogenic tumors, you can be pretty sure that it's malignant.
Sure. I realized, Keith, the series, the Chi-67 expression in CEOT percentage is even less than amyloblastoma, right?
It's about that. In our hands, the standard classic amyloblastoma, we get about 2 to 4% usually.
Yeah, around 4. Yeah, around 4.
Yeah.
You had some 1%, etc. Also.
So we had, in this we had 1 to 6% in our 8 cases. So it's about the same sort of figure.
I think we are done with the questions, but that was a good discussion. since your purpose was getting this international sort of collaboration going, and also we have Dr. Merve with us from Turkey, and can I request her to please join? We have Dr. Samudra, we have Dr. Nazanin from Tehran University, and there are also a number of people on YouTube from different countries, right from Australia to Europe. So I think they will also all hear you. So I think you can put forth whatever is your suggestion on that ground.
Okay, thank you very much. I think it's...
Is it Merve?
Merve, you're muted.
Sorry, just I tried to from the phone. Sorry, that was a great presentation, Keith. Nice to see all you in a good health. Firstly, I want to say this. It was an excellent presentation with all details. You left nothing to say yet, but just I want to share our experience from our department. We have for 50 years, 22 cases CEOT. And for pathologic perspective, especially if I don't see any classical epithelial features, I don't give the diagnosis. Especially you showed a picture with the non-calcified one, with the very large collagens and some small islands, odontogenic islands. For example, the first diagnosis in my mind is sclerosing odontogenic carcinoma, maybe. You can remember which pictures I think you can remember for the non-calcifying Y. So as you say that there is nothing distinct histopathological features, but for me, especially the classical epithelial features, I want to see to give this diagnosis. For the treatment, especially for my university approach, usually conservative surgical excision. But we have one case at the maxillary tuberous site. It's really goes with the two different recurrence. At the end, this patient had the hemimaxillectomy. So we have just one, but others we haven't got any recurrence. So I think you all mentioned that we need maybe big and large studies, but all the not only histopathological, but radiological and the clinical symptoms we put together to understand the real nature of maybe these lesions. And of course, molecular is another side.
Thank you, Dr. Merve. That was a nice contribution, sharing your experiences. I don't know if Dr. Samudra is joining.
Hi,
Yes.
Keith. Hi. Yeah. Thanks, Keith, for the nice presentation, and it's really informative. And from our side, actually, we have not analyzed CEOTs yet. We have cases CEOTs with some with clear cells and some collection of CEOTs. So we would like to do some analysis with your help, if possible.
Excellent. No, I think we can put together on the back of this a consortium that would allow us to do that. I think that would be very useful.
Yeah, thank you.
And yeah, just in response to Merve's discussion, you'll see, Merve, when you have a look at the paper, when we discussed Ali and Paul and my re-diagnoses of some of these cases, and in fact, some of them we did decide were probably sclerosing odontogenic carcinomas.
Yeah, yeah.
So now I have one question. If for all the people who have heard and who would want to, because we know that many of the departments, at least in India, definitely have a lot of cases. So if they want to actually join you and get together for this, how should they go about it?
I think anybody who has got a significant number of cases can join us. I'm quite happy for people to email me. My email address is fairly straightforward. It is just k.hunter@sheffield.ac.uk. And I'd be very happy to get any emails from anybody who's interested and has a significant number of cases to contribute to that. Tilak and I will try and coordinate something between us and see what we can, because obviously there are people with a lot of interest and expertise, Ricardo Gomez particularly being one, and also Adalberto is obviously somebody else that we probably want to involve. So there are groups I think I certainly have in mind that we would want to take this to.
Excellent. Okay, Dr. Nazanin has joined us. She is from the Tehran University. Yes, she's the head of the oral pathology department there. Yes, anything you would like to add?
Thank you very much. Thank you very much, Dr. Hunter, for the informative presentation. You mentioned all the details, and it was very much useful for me. Especially, we don't have much cases of these tumors, so we are not expert in that tumor, and it's challenging when it comes to more rare variants. So I have a question. Thanks for asking. My question is that recently I had 2 cases of peripheral CEOT tumor that both of them had the microscopic variant of that kind that you mentioned, the cells of arranging cords with little calcification and Langerhans cell rich. So it makes a question in my mind whether this type is more common in extraosseous areas or not, or that was just an incident.
I think the literature would bear that out, that the non-calcified variants are more common extraosseous. They are a higher proportion of them. You know, and I think, you know, if you've got something which is a shift in terms of the site like that, it does also support the fact that we need to be having a look to see whether that definitely is a CEOT or not. Yeah, so that would be borne out in the literature.
Thank you.
Thank you. Yes, I think we are, any other points anyone would want to discuss? And I think on YouTube now, the feed is only everyone telling you that it was a marvelous presentation. And yes, they thoroughly enjoyed it. And so I'm looking forward to the outcome of the interaction. So I will put your email in the description with the video so that anyone can get in touch. Hopefully we can get all the expertise and all the material combined and then come out with something that will really make a difference in the near future as far as this goes. And yes, now I have to share my screen 1 second. Yes, thank you so much. Thank you for the presentation. Although I have to say one thing, you can't just tempt us with a slide about another presentation and then not give it here, you know. That is not fair.
Yeah, well, I have a separate lecture which I could do some other time if you wish on malignant odontogenic tumors. I've already done that for John Wright's group at Baylor, so we can maybe talk about that, and I can do that one sometime.
Yes, because otherwise it's very unfair to tempt people and then just not do it. It's not right.
We're in the process of writing that one up at the moment. One of my juniors and one of my PhD students are writing that one up at the moment. So, but yeah, I'll be very happy to do that. We can talk about that offline, Mandana. Yeah.
Yeah, that's nice. Thank you. So thank you so much. That was very nice. And I know that took a lot of your time and effort. And I also have to thank Dr. Selvi. You have also put in a lot of effort in this. And thank you so much.
Thank you, Dr. Manna, for giving me this opportunity.
You are welcome. We also, yes, tell me, sorry.
Presentation, very good. And you have touched all the aspects of CEOT, like I said, right from the beginning. And yes, there are so many other things you said, like we need to find out the boundaries of the variants of CEOT. So we are all looking forward to do collaborations with you. We hope you'll be able to help us out. Thank you, Dr. Keith.
Yeah, you're welcome. It's been my pleasure. And thank you for having me today.
Thank you. And also thank you to the rest of our panel. Tilak Ratne sir, Dr. Merva, Dr. Samudra, Dr. Mahtavi, thank you. It was, and of course, Dr. Raghu. And that made everything possible. Now, small, of course, this is about the coming Tuesday's event, and we are back to Tuesdays. This one is a back to basic fundamentals presentation. So, sorry. Okay. And it is about salivary gland tumors, and one more, of course, soon by the 21st of Feb, we are organizing an international case presentation webinar. So this is only the date. The details will be out next week. And it is with a difference because the people presenting are going to be only our young colleagues with less than 5 years of experience. So the idea is to give them a chance. And of course, everyone can attend, but just keep an eye out on that. And at the end of it all, thank you so much. And today also we had a very good attendance. We have had over about 250 people who have been watching and who are still watching because they have logged in at different times. So it's been good. And thank you so much. Hope to see you all soon again. And I definitely hope, Dr. Hunter, that you will find the collaboration you need to find us all the answers we need. All the best. Thank you. Bye.
Bye, everybody.
Bye, sir. Bye.
Take care, Keith.
Bye.
Bye, Tilak. Bye, Mandana.
Bye. Bye.
Bye, Selvi. Bye. Bye, Marwa.
Bye. Take care of yourself. Bye.
Yes,
you
bye,
too.
Marwa.
You
Thank
too.
you.
Thank
Bye,
you.
See you, Samadra.
Nazanin.
See you, Priya. Bye.
Thank you, Dr. Tilak Ratne.